Alrighty, the low-cost benefit option was supposed to increase the affordability of med schemes among lower-income households. But was recently, just at the end of last year, given the axe by the Council of Medical Schemes, who argued that they don't guarantee value for money and are more likely to drive members to access healthcare from public facilities. We thought we should have this discussion about whether those options actually were a meaningful platform and what, given the fact that the Council for Medical Schemes suggests in light of the NHI they feel they should be rescinded, whether or not that actually is a viable option. We all have our perspectives on the National Health Insurance Scheme. As I said, Barry Childs, CEO of Insight Actuaries and Consultants, joins me in studio. Good morning, Barry.
Good morning.
Thank you so much for joining us. Of course, from an actuarial perspective, excellent insight into what this particular subject, both from a perspective of his specialties in health policy, product design and analytics, and risk management. He's been in this consulting space for good on 15 years with his consultancy, Insight Actuaries and Consultants. Dr. Brian Ruff, CEO of PPO Serve. Welcome back to Breakfast with Refilwe. How are you?
I'm good. Thank you for having me back. And how are you?
I'm alive, thank goodness, and not paying my medical aid at the moment. It's the beginning of the year, so there's still something in my savings. All right, gents, you have two slightly different perspectives in terms of what you don't like about what's happened here. Maybe, Barry, you can kick off for us what your perspective is on this move by this Council for Medical Schemes.
Thanks, Refilwe. So, just to cover something you mentioned already, that these products were intended to come to market to provide lower cost alternatives to medical scheme cover, which is quite expensive and only affordable for people with higher incomes, but still provide a valuable service. So the issue, there are two main issues, I think, why we find ourselves in this position. The first one is the communication and process issue, which is what caused all of the sort of uproar and reaction to the Council for Medical Schemes saying, well, these products are going to be stopped. Just to say one thing, they're still active. These products are still going. People are still getting service, still paying their premiums, still accessing benefits. But what the registrar indicated is that by 2021, he's going to stop them. So the process, again, the communication and the process seem to be a little bit back to front because he's engaged the industry now on a roadshow, very conciliatory, very engaging, very discussive to say, give us your feedback. We want to hear what you've got to say. We'll make a plan. We're going to make this work. But when you look backwards, the first notice that came out was saying these products must be wound down. We're not going to give any more, etc. And that caused a lot of problems. That's the first big issue, just the process and the communication. The second one is these products exist in a health reform environment with some uncertainty. So we have NHI, and that dominates the narrative about where we're going as a country in terms of health reform. But there's really no clarity on what role private sector funding is going to play. The role of medical schemes, the role of health insurance products, etc. And so it's very difficult for the regulator to find a happy place for these products without clarity over there. And that's sort of the difficulties that we find ourselves in.
And in this grey area of reform, I mean, it seems as though this is not the first time we're getting, shoot from the hip announcements and then turn back for consultation. I mean, the very NHI announcement was a little bit like that, wasn't it?
Well, yes and no. I mean, it took us 10 years to get the white paper and then the bill following. So there was a lot of work there. Okay. But, I think anyone who's engaged with government in these, and I'm sure other policy areas, would tell you that it's, you're sort of waiting for a long time and then all of a sudden there's a flurry of activity and you have to deal with that.
But in principle, what the registrar is saying is not something that you're against. You just don't like the mechanism in which it's been brought to market.
So I don't think they should be prohibited. Yeah. I think there is a place for these products. They do provide a valuable service. What he's been saying in the engagements with industry is that now we need to understand these products. They did some analysis that showed some of the products gave poor value for money. So when I read all of what they put out, for me, what that means is these products have a place, but they must be properly regulated. There is a big risk that these products that are sort of not governed by the very stringent Medical Schemes Act could offer poor value for money for consumers, and nobody wants that. So you can get products that take chances and offer high premiums, low benefits. That's not what you want. So they should be properly regulated.
Okay. As a medical provider yourself, Dr. Ruff, Brian, what are your perspectives on this particular ruling?
So I guess my perspective is to step back and look at the bigger picture And I think Barry started off by saying that these have been positioned as alternatives to medical schemes because they're very expensive and therefore inaccessible to many South Africans. And I think the right perspective is to wonder or to understand the role that these, if we may call them gap products, including this primary healthcare product that we're just talking about, but also including the gap cover that covers the difference between what a specialist charges and your medical scheme will pay if you're admitted into hospital. These were, in a way, these were gaps in the medical scheme cover that medical schemes have done nothing about over, some 20 years of regulation, and the regulator has been remiss in not addressing them. And we could talk about that, about why they haven't done that. But the effect of all of that has been that the combination of these gap products have been offered by these health insurers as an alternative to medical scheme membership to young and healthy people, because obviously they can underwrite and exclude people in a way that the schemes can't. And the effect of that is that one of the major drivers that make medical schemes expensive is this unbalanced benefits that we have at the moment, and so that in order to get basic stuff done, you need to be admitted in a hospital where it costs, maybe 10 times more than if it happens in the out-of-hospital environment. So the effect of allowing these products rather than actually just going and fixing the medical scheme environment and filling these gaps is to have an aging population, which means that prices go up, making the problem even worse. So we're in a kind of a vicious cycle. So, I don't disagree with Barry that it could have been handled better, but clearly these products proliferating is in no one's long-term interests, and we need to be looking at better solutions.
If I can just take that a little bit, I'm with you, I think, Brian. I just want to make sure I am. If I'm hearing you correctly, what you're saying is that the industry, particularly on schemes front, is currently incentivized to, I suppose, compartmentalize elderly and less healthy from, and which would be more expensively insured from healthy and young, and that by creating the low-cost benefit option, you intensify that separation.
Well, what we want in a medical scheme, obviously, which is essentially a not-for-profit entity with cross-subsidies between old and sick people and young people. You want everybody involved.
Yeah.
These products aren't regulated in that way.
Okay.
And so these products are allowed to exclude older people or to market specifically to young people. And we see this in the literature, in the review that I guess the council or the data the council has put out. They're paying out less than half of the money that they're collecting, and they're also taking a considerable amount of profit out of these. None of that would be allowed in a regulated medical scheme environment.
Okay.
And so they're not very good for the medical. The role that they're playing apropos of the medical scheme is a big problem. But the medical schemes are equally remiss in the sense that why aren't they offering comprehensive primary care out-of-hospital benefits? Why do you run out of your medical savings account if you're elderly and sick in February? Yeah, and then after that, and then you have to be admitted by your doctor to have something that would cost 2,000 or 3,000 rand suddenly costs 30,000 rand because it's happening in a hospital. So it makes no sense, but this isn't the right solution.
Barry, this cuts right to the core of your actuarial models, and anecdotally, I don't know a single person, elderly or young, that doesn't have concerns around heavy paying in and feeling like inappropriately covered. To what extent would you agree with Brian, and where would you push back?
Yeah, so Brian raised one interesting point, which is, why aren't schemes offering primary care benefits like this? So there are many different angles to approach that problem from. But as it pertains to this low-cost benefit option issue specifically, this is another issue. So medical schemes actually do want to offer these products in the not-for-profit, well-regulated medical scheme environment. abiding by all of the normal medical aid rules, like not excluding the old, charging everybody the same premium, etc. But the council has not allowed medical schemes to register products in this market. So, the argument is they're not insurers, so they don't get to apply for this particular kind of exemption. It's sort of a bit nitpicky in terms of the way that the regulations are being considered and the exemptions are being granted. So medical scheme, certainly many of our clients are very keen to play in this market, and then that should sort out the incentive issue. If insurers are taking a chance and overcharging or taking profit out of the system, and medical schemes are not, those products should be cheaper. They should compete them out of the market. So there is a market there. Whether people are running out of cover, savings accounts running out in February, etc. I'm not sure we'll have time to get into all of the nuances of those arguments. But I agree with Brian on some of the points that overall medical scheme benefit design regulation needs to be significantly improved, and there is a process going on for that at the moment to put primary care back into minimum benefits. So all medical aid options will have to provide some kind of primary care. But again, that's the sort of regulatory limbo we're in at the moment. We're trying to fix all of these problems at the same time while NHI is going through its own processes.
So I was just chatting during the break with Barry a little bit about the difference between sort of the insurer's role as well as you know what, Max in Noordhoek would like to ask the question. Go ahead, Max.
Hi, Refilwe, and hi, guests. I'm really interested in health providers or medical schemes have this very interesting, because of the regulation, this hybrid organization where there's a non-profit medical scheme and a for-profit provider, and they can possibly have very competing interests. I want to understand, is there clear governance between the two? And if there are there any potential conflicts of interest where the power of the for-profits can control the non-profits of the medical scheme?
All right, thanks very much, Max. And maybe for the purposes of sort of this particular topic, we can try and deal with that with respect to the low-cost benefit options. Or is that more general?
It would be tricky because the low-cost benefit options aren't schemes per se. Hi, Max. Could I just understand, when you say providers, are you talking about administration providers or healthcare service providers?
Max has dropped.
Oh, has Max dropped? Okay.
Yeah, but I think he means administration.
Okay, yeah, that's typically where the confusion comes in. So medical schemes operate typically on two bases. One is called self-administration, where the scheme, which operates as this not-for-profit trust, govern themselves, they run themselves, they employ all their own staff, call center agents, etc., and they run on that basis, like a self-contained not-for-profit trust. Most medical schemes outsource the administration function to a company, a PTY limited company, and those companies typically operate on a for-profit basis. Sometimes the brand is the same as in the case of Discovery. You have Discovery Health Administration and you have Discovery Health Medical Scheme. In other cases, they're not the same. For instance, the Bonitas Medical Scheme and Med Scheme being the administrator.
Right. And where do some of these costs come from? And Brian, I'm going to ask you to come and defend your people, because sometimes when you go to the actual medical schemes, they're like, well, your medical providers are the ones that are charging these high prices, and that's actually the problem in the system, and that's where the regulation needs to come in. I know we've spoken about this to some extent in the past, Brian, when we were talking about NHI and the range of interventions that you would like to see within how that is rolled out. But to what extent in this particular context would you think that that's a fair assessment?
So if I can just answer Max's question, because I think it's a fascinating and important question. I think this low-cost benefit option discussion is an example of a very worrying set of perverse incentives. So let's just think this through. So I'm a major medical third-party administrator of a medical scheme. The medical scheme, for regulatory reasons, has inadequate benefits out of hospital, as a result of which the expenses that I incur are much higher than they need to be, but I actually my earning is as a percentage of that. So I have no real incentive to improve the situation because actually that's where I'm earning money. And now an opportunity becomes along in which I can start a new business, an insurance business not regulated by the Council of Medical Schemes, and I can sell to my same members whose healthcare costs I'm meant to be the steward of. I can sell them another product and make another form of profit. It seems to me that's a very worrying situation.
And so when you say out of hospital, you mean as in the primary care provision?
Yeah, exactly.
And that's
so,
okay.
So there's a very worrying contradiction there. There's a very worrying set of relations. So I think Max is spot on. And in a way, I think, if you understood the politics of why the council acted when they did, it's exactly because of this reason. However, and that's not to excuse them from finding an alternative solution. So to answer your question directly, in my view, and this is why PPO Serve exists, there's nothing to stop a team of doctors getting together, general practitioners working with allies, maybe a physician or a pediatrician, and saying that I'm going to get out of the business of fee for service. So every time someone comes to see me, I give them a bill. I could move to a situation where I say, we've got together as a team, and we will look after your health care, and we'll enter into a contract in which we look after your health care regardless of how many services you need, and actually part of our income will become related to the outcomes that we produce for you. And that's a much better situation. So part of the problem at the moment is that doctors are paid to work alone, and therefore they can't on their own. It's not easy for them on their own to get together and just fill this gap. You've got to have a third-party purchaser who says, oh, actually, like Gems, I guess, is doing with us, we will contract with you to get together as a team and look after patients in this primary care space.
Okay. Barry, you disagreed.
Just on one point. As it pertains to the LCBO options specifically, these are not products that are being sold alongside medical aid cover.
Okay.
They're being sold to a different market with lower incomes that can't access the medical scheme market.
Okay.
Brian's argument has some truth to it as it regards to gap cover, which is sold on top of medical aid cover. That again has a long history of regulatory decisions.
Now, in principle, I kind of refuse to buy it.
That's sort of the issue.
Especially when it comes from the same company.
That is exactly the issue. So again, it has a long history. Around 2003, a particular gap cover provider won a very prominent court case, and that really legitimized that market. And the medical aid industry was waiting for some years for the council, who had promised to, fix the wording in the Medical Schemes Act so that the gap cover would be seen to be doing the business of a medical scheme. And they never really got around to it. And so everybody was waiting around for that to happen, and they said, well, it's not going to happen, then we may as well have a product in that market also.
Sure. All right. You guys have got the same interest in terms of, I'm sure you want to see a healthy population, but you have some competing positions within the industry. Where would we agree, if we had to close out, unfortunately, already this discussion, where would we agree we need to move toward with respect to low-cost benefit options that seem to be a reasonable space where both sides of the industry might land up, positively moving?
Do you want to go first, Brian?
You go ahead, Brian.
The model that to some extent the Medical Schemes Act and the NHI, I guess, is based on is a purchaser-provider split, not dissimilar to what we have at the moment, except that it's comprehensive. And so what I would like to see is a situation where all South Africans enjoy access to the same benefits, which is a balanced package of strong out-of-hospital primary healthcare benefits, and you get hospital cover when you need it, and that there aren't gaps in cover for specialists. And it goes back to that previous question, which, as Barry said, why do specialists charge so much more than people, and what was the framework meant to do? What the framework was meant to do, and I guess it's where I would like to go, is to make specialists feel comfortable to join a network in which they earn enough money to that is consistent with the work that they do and the skills that they have. Schemes were unable to convince them of that, because, frankly, they weren't willing to change the model away from fee-for-service. So we ended up in a situation where there are gaps all over the place. I think it's entirely possible to be back on a road where there are comprehensive benefits, and the people who are doing the purchasing are buying on behalf of everybody, and They're buying value, and that's the NHI in a way done properly. And frankly, healthcare costs would be, compared to private sector prices, they may be a third of what they are now.
And over to you, Barry.
Thanks, Refilwe. So my view would be that the NHI reforms are underway. They're going to go through their processes, and they'll dominate the narrative on how the health system is going to look for the foreseeable future. But implementation is going to take a long time. Certainly to get to the one single fund paying for comprehensive care for everybody with no co-payments, sort of the vision that they've laid out in the bill. That's going to take a very long time. In the interim, what I'd like to see is a much clearer regulatory pathway and trajectory for the role of medical schemes, where the LCBO options fit in, and any of the other affiliated products like gap cover. There's no coherent framework at the moment for how all of these things fit together. And I think our country would do well just to give people certainty, because healthcare is very important to people. Some people leave for these kind of reasons, healthcare, education, etc. So some certainty in a well-regulated environment that fits within the overall trajectory while we're waiting for the NHI reforms to mature, I think would do us all well.
Sound like reasonable suggestions from both of you, gentlemen. Thank you so much for joining us on today's Wednesday panel. Dr. Brian Ruff, is CEO of PPO Serve. Barry Childs joins me here, CEO of Inside Actuaries and Consultants, also the Healthcare Committee Chair at the Actuarial Society, and obviously both very invested in finding the right solutions for us.